This is Dr. Leanne Brady, and I want to welcome everyone to a quick guide to bonding and cementation. I want to start out by thanking both Viva Learning for hosting this program, but also for our sponsor, GC America, bringing us this kind of great education, especially in the world of virtual education, which I know we all find easy and convenient, just helps us all be better at what we do for both our patients, if you're a manufacturer rep, for your clients. So I really want to thank them for putting this on today. So as we get started, I just really wanted to start with this whole concept of bonding, cementation. When I was in dental school many, many years ago, we used to actually call things like zinc phosphate luting materials, and we didn't use the term bonding or cementation. And so I went to the Journal of Prosthodontic Terms, the Glossary of Prosthodontic Terms, just recently to kind of look these things up. And so in dentistry, we define luting to be anything where we fasten, attach, or seal. So the truth of it is both bonding and cementation fall under that category. So all of the materials we're going to talk about today would technically fall under the category of luting agents. Specifically, bonding is defined, as you can see here, as an adhesive technique. It requires doing something to prepare the enamel in the dentin so that we actually mechanically and chemically attach the restorative material to the tooth. That's different than cementation, because in cementation we're not really going through the steps in a process to prepare the tooth or prepare the restoration. We're literally just putting something in between those two things to kind of connect them together. And I wanted to really start here because often this can be very confusing when we talk about are we truly cementing? Are we bonding? And a lot of the materials we use today identify themselves as resins. So if they're resin-based, sometimes we want to assume they're bonding, but some of them can be put in the category of cementation. So I just thought this was kind of a good place for us to start. And with that, then, let's talk about what are we trying to accomplish. When we think about the process of either bonding or cementing and the materials and the techniques we use, there are a lot of things that we're going to be concerned about that are going to go into our decision process. So one of the most common ones that we talk about is bond strength. And when we think about bond strength, I think for most of us in dentistry, that for us is about retaining the restoration on the tooth. And we automatically denote that things that have a higher bond strength, materials that have a higher bond strength, therefore have greater retention, and we have a much lower chance of losing the restoration or the restoration debonding or de-cementing. And in some regards, that's true at a kind of a high level, but bond strength in and of itself is not the only deciding factor that goes into the ability of a material to retain a restoration on a tooth. We also have to look at things like modulus of elasticity and the flexural strength of that material and the hydrophilicity or hydrophobic nature of the material, how much water absorption there is. We have to look at a lot of different factors to figure that out. And it's not as simple as just talking about bond strengths, although that is going to be one of the material properties we talk about. We also talk about microleakage. I mean, when we really think about restoration retention, truthfully, probably more of the time we're replacing a restoration because of microleakage, because bacteria has gotten underneath the restoration. We've got now recurrent or secondary caries. We've got bacterial infiltration that's resulted in a problem with the pulp of the tooth. So making sure that the material, the layer that's between the restoration and the tooth is going to survive in the oral cavity, isn't going to have voids, and isn't going to dissolve or allow bacteria underneath is really going to be critical in the longevity of our restorations. Sensitivity is at the top of all of our lists. We all like it when patients walk out the door with a brand new restoration, and the next time we see them and say, how did it go? They say, fabulous, no problems, never knew you did anything, versus the patients who are paging us or calling us that night or the next day or 2 weeks later or 2 months later, telling us that the tooth still bothers them and they still had some temperature sensitivity or just a tenderness in that tooth. So obviously we want materials that help protect the pulp, soothe the pulp, prevent sensitivity, which is also related to microleakage and voids in the material. When we then get to the pieces of actually the handling properties, the technique of using that, we all like materials that are easy, efficient, effective, convenient, fewer steps. We like to know that if there are multiple materials required for a process, that all of those materials are compatible with one another, so that the use of one material doesn't prevent another material from working the way that it ought to. So, I think this is it's a fairly good list, and we talked about some other things, which is why this is such an important conversation. The other reason that talking about bonding and cementation is important is because our worlds have become much more complicated today than they were, let's say, when I got out of dental school in the late 1980s. I placed a really large variety of indirect restorations, which you could count on one hand because it was PFMs or gold partial coverage, and I really in those days had 2 or maybe 3 materials to choose from to put those restorations in, and zinc phosphate and glass labs, or polycarboxylate materials like Duralon, the early days of some of the glass ionomer cements. So we didn't have a lot of different techniques. We didn't have a lot of different clinical procedures. Therefore, we didn't have a lot of materials to choose from. That is not true today. Most of us put in a fairly wide array of materials that may still include gold inlays and onlays, gold crowns, PFMs, a lot of our new all-ceramic systems, and we have lots of different types of materials on the market to bond and cement. So that's really why this has become a very thoughtful decision process. So when we think about bonding or cementing, do we go to the process of preparing the enamel and the dentin, preparing the inside of the restoration so that we get that mechanical connection, the chemical connection between the two, versus using a system that literally just physically connects the restoration and the tooth? There are some things that we need to think about. Retention form, isolation, and then, of course, the materials. So let's look at that more specifically. So when we think about retention form, we need to go back to some of the basics of doing prep design. Retention form is taught as opposing walls of the restoration that are somewhere in the range of 4 to 8. I've heard people say 4 to 10 degrees of taper now that we do all ceramic restorations. And so we need walls that are not parallel, but they approach parallelism, so that we actually get physical retention, mechanical retention from the shape of the preparation. We need those walls to be about 4 millimeters high at a minimum to give us that physical retention. We'd also like to have properties that support cementation, so material strength, so minimums of 1.5 to 2 millimeters of occlusal reduction for most of our materials, although zirconia is now an exception to that, and zirconia restorations at 0.5 millimeters occlusal reductions can be cemented, and then 1 millimeter of axial reduction, so we don't want thin materials on the axial walls. So if we have a preparation, a tooth preparation that has all of these features, minimal taper, so really nice walls that create mechanical retention, significant wall height of 4 millimeters or more, an adequate reduction occlusally and axially to support the strength of the material, now we have the ability to cement. We could still choose to bond, but we need retention form in order to cement. In the absence of retention form, we need to be thinking about bonding this restoration in and actually micromechanically and chemically trying to connect the tooth and the restoration. Isolation is going to be another important criteria. Cementation, and most of our materials that are rated for cementation are not highly technique sensitive from a standpoint of the humidity of the patient's exhalations and saliva contamination or sulcular fluid contamination. If we want to bond, we actually want to work through a process of preparing the tooth, etching enamel and dentin, priming, going through all of those steps. That's a very moisture technique sensitive process. And so if we're going to bond, we need to be thinking about how are we going to isolate in order to get maximum bond strength, maximum material capabilities. And we also need to be asking ourselves the question, can I isolate? So, sometimes if you're working on a patient on a lower second molar, they have a really large tongue, they have a strong gag reflex, they're not going to be a patient who will easily or comfortably allow you to place a rubber dam or other forms of isolation. You may actually have that inability to isolate adequately sway your decision about how you're going to prep the tooth. So I'm going to do a prep that has adequate retention form because I feel more confident if I cement this restoration versus having to bond it in a field that I don't feel confident with isolation. If you've got adequate ability to isolate, then you again can feel comfortable bonding, or you could still choose to cement. So a lack of isolation should drive you in the direction of cementation and prepping the materials for cementation. A lack of retention form should drive you in the direction of materials and processes for bonding. Another thing that we can think about with isolation is, as I said, sulcular fluid, and how are we going to handle whether there's hemorrhage from gingival tissues or we've got sulcular fluid. Ideally, of course, we would all think about working under a rubber dam. Well, that works for those of us who choose to do that for direct restorations. It becomes more complex for indirect restorations, and especially if margins start to approach crest of tissue or our subgingival. And so there are ways that we can control that. So using things like retraction paste, there's several of those on the market from different companies. They're fabulous for controlling hemorrhage. They act as great vasoconstrictors, and they can also get the tissue out of the way a little bit for you so that you can clearly get to the margins, clean your cement. Doing something like placing a single cord so that you can control that before you do your bonding process. So there's a lot of things to think about if we're going to work through that thought process of bonding and how we're going to isolate. And then the last piece of the puzzle that we talked about is material selection. So we have materials that have to be bonded because the material itself doesn't have adequate inherent strength to be cemented. So when we think about materials like feldspathic porcelains or most of our pressed porcelains, there's a lot of different name brands for that. You could think about Authentic, Noritake, Empress. But if it is a true feldspathic or lucite reinforced ceramic, whether it's powder liquid fabricated or it's pressed or it's milled, those materials need to be bonded to the tooth in order to gain strength to be fracture resistant. And then we have materials that truthfully can't be bonded, not in the way that we think about being able to prepare the material and get that kind of an attachment. Those would be materials like metal ceramics or your classic PFM crowns. Now, we may still put them in with a cement, quote unquote, or a material, a luting material that we will think will give us bonding, because we may have porcelain margins on that metal ceramic crown. So that's kind of a crossover type of a restoration. Zirconia, really right now zirconia falls in sort of a gray area. Classically, we've thought of zirconia as a cemented material and that we can't really bond that material. With that said, several of the manufacturers and several of the key opinion leaders and academicians out there are developing protocols for bonding zirconia, for creating a micromechanical and chemical retention. So ultimately, I think zirconia will fall in both categories. You could choose to cement it. You could choose to bond it depending on the clinical situation. Lithium disilicate, which most of us refer to as EMAX, does live now in both categories. You can bond lithium disilicate, and you can choose to cement lithium disilicate. Part of that decision of bonding or cementing will go right back to retention form, full coverage preparations with retention form, adequate thickness, cement it. If you've got partial coverage restorations where you've got lack of retention form that's mechanical, or you're doing lithium disilicate in thinner layers, you're doing a veneer, you're now going to bond that. And then, of course, things like alumina, Cavtech fall in the cemented category, although not many folks continuing to do those materials. So thinking about are you going to bond or cement is truthfully a treatment planning decision. It's actually something that gets decided, or it influences your other treatment planning decisions all the way back before you prep the tooth. So figuring out, do I have a short clinical crown here, so I'm going to lack retention form? Is this a place I'm going to have trouble isolating? All of those things, and what material am I going to use here, are going to drive you to already kind of be thinking bonding or cementation. And your preference for bonding and cementation might drive your material selection and might drive the way you prep a tooth. So that's allowed also. So that those decision processes can kind of go in both directions. So I want to start out with what I would consider the more classic cementation, the way we've defined it. And we actually have quite a number of materials or families of materials that fall into this category. I mentioned two briefly, zinc phosphate, which I'm kind of thinking very few people use anymore, and polycarboxylates. Some of you may know that as Duralon, although Duralon still has some market share hold as a temporary cement. But for most of us today, when we think about cementation, and we think about materials in the category of glass ionomers, resin reinforced, or what we call resin modified glass ionomers, or a group of materials known as self-etching and self-priming resin cements, or self-adhesive resin cements is another way that we can refer to those. But before we actually get to cementing it, we actually have to do a little work with the restoration. And so the very first thing with the restoration, obviously, is we're going to try that restoration in. And there are different ways to do this. For single units, most of the time, I'll just put the restoration in. I'm going to make sure that the margins are sealed, that the fit is good. I'm going to check the occlusion. I'm going to check the interproximal contacts so that I know that this is a restoration I'm ready to cement. If you're trying in an all-ceramic restoration and you really want to get a good sense of the final color of the restoration, I suggest putting either water, moisture on the inside of the all-ceramic, or you can use try-in paste of some kind or glycerin. But you do want to sort of connect the ceramic to the prep, because the color of the dentin will influence the final color of the restoration. Obviously, for metal ceramics or zirconia, alumina, things where the core is really opaque, that's not going to have an influence or be necessary. I mentioned just Mach 2 here as a way to, if you're trying in multiple restorations, so you've done a quadrant or an arch or a sextant, and you really want to be able to floss between those, you want to be able to check your occlusion, a tiny little dab of Mach 2, as you see in this photograph inside a full coverage restoration, will hold it in and allow you to do those things. And again, these are techniques for materials that are strong enough to be cemented. So we're not going to do this with materials that need to be bonded to the tooth for strength, like feldspar or lucite reinforced, because we really want to be testing all of those things like occlusion after we've got that strength, we've got those bonded in. Okay. The next piece of this puzzle is preparing the restoration. Now, this is kind of an interesting conversation, because one of the things about cementation is that it can actually be done quickly, efficiently, and with very few steps. So for some of you, preparing the restoration once you've tried it in could be something as simple as just wiping out the inside, getting out any try-in paste, drying it, air drying it if there's saliva or contaminants on the inside of the restoration. And for a lot of our cements, actually, they'll still work in that environment. I do suggest at least a minimal amount of cleaning of the inside of the restoration, and that can be something as simple as taking a bit of ethanol on a cotton pellet and just cleaning out the inside of the restoration. If you really want to go now to the process of cleaning and preparing that restoration, which you can do in the process of cementation, it's not required, but you can do this, then you may think about air abrasion, depending upon the material. So metal ceramics can be lightly air abraded. You want very small particle size, so less than 15 micron. Zirconia, air abrasion is actually the preferred methodology of cleaning it. For some of our materials, you can actually use phosphoric acid etching gel as a way to clean the inside of the restoration if you really want to. But for most of the time for cementation, our cleaning process is going to be something very simple, like just wiping it out, a little bit of ethanol, maybe potentially using a cleaning material. And for most of us in cementation, we're not going to now condition the inside of the restoration by using any kind of a silane or a polymethyl methacrylate. We're just going to clean it and move on to cementation. As far as the tooth is concerned and cleaning and preparing the tooth, again, one of the pieces of cementation is that quick, efficient, not many steps. And so, again, you could do something as simple as just trying to sort of dry the tooth. I do recommend cleaning the tooth, the prep, before cementation. Many of you may want to use a desensitizer, so something that has glutaraldehyde and HEMA in it, or some kind of an antimicrobial, so chlorhexidine. Glutaraldehyde also is antimicrobial, so you may use that both to clean the prep and to sort of treat the dental tubules. So thinking about how you're going to clean the tooth. You can use air abrasion. You don't need to do those things for cementation, but many of you do that, and that will still work in this process. And now we're going to actually cement the restoration. So when we think about cementing the restoration, we have three groups of materials. So we want to talk about glass ionomer, and really glass ionomer, I almost want to say, is still kind of the gold standard in this category of products. It's many, many, many people's go-to cement. So restoration that's strong enough to be cemented, that you have adequate retention form, and you're going to go to glass ionomer. So what is it we love about it? Well, we like the fact that it's quick, easy, and it's very dependable. So, when we talk about glass ionomer and resin-modified glass ionomer, we really don't talk a lot about bond strengths for these materials. But the truth is, historically, with a lot of research studies, these restorations do not come out if we're using these materials in the appropriate place. So you don't need to etch the tooth. You don't need to use any kind of a dent adhesive or primer and resin. You can pretty much use glass ionomer under any restoration where the material itself is strong enough that it doesn't have to be bonded for strength. So metal ceramics, zirconia, lithium disilicate, alumina, Captech, any of those materials. One of the things we like about glass ionomer is fluoride release. And many people talk about fluoride release and the potential that has for help preventing secondary caries and marginal leakage, which we know is one of the most common reasons we replace these. And one of the things that's kind of unique to glass ionomer is it really has some optimal physical properties, in particular thermal expansion, very similar to tooth structure, which really means as the patient creates thermal cycling in their mouth. So they're drinking something cold, they're drinking something hot, or they're eating ice cream and drinking hot tea at the same time. So they're really magnifying that thermal expansion because it's going to respond very similar to the tooth structure. You don't get a breakdown of that fit of the restoration and of the cement layer the way you can with other materials that we use. Glass ionomer comes in lots of formulations. You can mix it, you can triturate it. Most of these are opaque, so one thing to know about them is they are an opaque white color, not a deal breaker under an opaque restoration. Now, more recently, what's come onto the market is our resin-modified or resin-reinforced glass ionomers. And advantages of these. So we still get a lot of the advantages of glass ionomer. We get the comfort that we feel with glass ionomer. So for many of you, Fuji is a name I think every dentist associates in the world of glass ionomer, whether that's liners under restorations or cements. GC America has that reputation because we've used these materials for years and we know we can depend on them. So in their glass ionomer line, they now took that Fuji name and they pulled it forward, and we have things like their Fuji Sem and their Fuji Plus that are their resin reinforced or their resin modified glass ionomers. So again, quick, easy, efficient, highly effective cements, low sensitivity. You don't have to etch, you don't have to use a bonding agent. With the resin-modified glass anomers in the Fuji family, we now have an extended fluoride release. So that fluoride release actually occurs over time. Because of the resin that's been added, we now have an added benefit that works great from a chairside perspective. You can actually tack cure. So you can actually pick up a curing light, and you can do, I typically for these do somewhere between 5 and 10 seconds, buccal lingual, and now I've got a gel phase. I can clean that excess cement. Because of the resin, it's also lower solubility, so it's more durable in the oral environment. And again, these are opaque, and we have lots of different delivery systems. So if you like an auto mixing tip, you can have that kind of a dispensing system. If you prefer to do them where you triturate, you can do that as well. The last material in our cementation category is going to be what we call our self-etching, self-priming resin cements. From GC America, their self-etching or self-adhesive resin cement is what they call GCEM Link ACE, which you can see here. And this category of cements, I like to refer to them as the CEMs because so many of the different products have CEM in their name, have become really popular. Well, one of the reasons they're popular is because they're beautiful. They are translucent. So as we've all moved into the world of more translucent restoration, so we're doing a lot more all ceramics, we're doing a lot more EMAX, then we really think about the fact that we want a translucent cement. So we don't want to put something white underneath that. So that has made us, even though we love our glass ionomers, we love our Fuji, we love our resin-modified glass ionomers, but I've got this beautiful translucent restoration, we want a translucent cement. So again, with these self-adhesive products, you do not have to do anything to the tooth or the restoration. Remember, you've got retention form. This is a place where you're going to depend on physical cementation. These are great products. They come with auto mixing tips. Again, you can tack cure. Now, with the GCEM in this particular case, the recommendation is to tack cure for about 2 seconds. So 2 seconds buccal, 2 seconds lingual. The material will now go into a gel phase. Now you can clean the cement. Now what you want to do is you either want to hold that restoration in under pressure for about 4 minutes until it gets to a full chemical set or dual cure set, because these materials are dual cure, so they'll set by themselves or they'll set under light, or you want to apply 20 seconds of light on each of the surfaces of the tooth so that you now get the material to a full light cure, and then you can release the pressure. So one of the things with any of the materials in this, when we talk about bonding and cementation, is number one, you need to think about how you load the restoration, and you need to make sure you express excess. You do want to see excess out at the margins when you cement or bond something. If you see no excess, the chances of a marginal interface void are high. So you want to see excess come out. You're going to figure out your process for cleaning that excess, but you need to hold the restoration on. The viscosity of the cement and the pushback will actually lift the restoration if you let go of that pressure before it's fully cured. So what are the advantages in this category? Again, ease of cleanup, 2-second tack cure, very low solubility because it is a resin product, and they're beautiful, they're translucent. So, one of the things to think about with any cement is at what point can the patient now fully function? And a lot of our cements really take up to about 24 hours to reach their maximum cure and their maximum bond strengths. And so one of the things to think about is just talking with your patient about the fact that you want to caution them about eating sticky or chewy foods or eating nuts or flossing and popping the floss up for that first 24 hours after they've had a restoration cemented. But know your cement. So one of the things that I like about the GCEM Link ACE product from GC America is that it doesn't have that 24-hour rule. So pretty much by the time my patients have gone to the front desk and made their next appointment or checked out, that material is fully cured. So that we now have the full amount of retention and bond that we're going to get. The patient doesn't have to worry about that. So definitely want to think about knowing the products that you work with and what are the recommendations for that. Now, one of the things that's very easy about that is all of these instructions live on the web. And so if you're not 100% familiar with the rules or the recommendations from a manufacturer for a specific material that you're using, you can go right to the website. And so, I do this on the GC America site all the time. I'll just click in, I'll just drop down under products, you hit cement. It gives you all of the cements that they manufacture. You can just click on the particular product, and right over in the lower right-hand side, it actually has a link that says instructions for use. You can pull it right up on your computer, and it'll tell you how to use the products even in different clinical situations, which can be really helpful depending upon what you're doing. So that really is now cementation. So now I want to move into the idea of talking about bonding versus cementation. And really one of the defining differences to me between cementation and bonding is the technique sensitivity of how we do that and the precision that's required as soon as we move into the world of something that's adhesively connected. Okay? And that's going to be one of the differences as we think about that. So if you want something quick, easy, dependable, then you're going to live in the world of cements. Bonding requires things like isolation, but do we need it? We absolutely do. Most of us today do preparations that are don't have full retention form and resistance form. Partial coverage all ceramics is becoming really the norm. We're moving away from doing full coverage restorations thanks to the fact that we have so many beautiful all ceramic materials that are strong enough that can create aesthetics, and because we have adhesive techniques. So the fact that we have available to us, let's take advantage of it. So when we think about the world of true bonding, we have basically two big groups of material. We have materials that fall in the pure light cure realm, and we have materials that fall in the dual cure realm. And so when we differentiate those two, I usually think of light cure materials are most appropriate in the anterior of the mouth because there's two features of light cure materials. Number one, you need to know with confidence that you can get light all the way through the restoration to the bonded interface and fully polymerize or fully cure that material. And light cure materials are absolutely predictable in the fact that they won't color shift in the mouth because there's no chemical, there's no catalyst in there. Dual cure materials I typically think about using in the posterior part of the mouth because that's a place where it's hard to dependably get light through a restoration. So I want dual cure chemistry so that I know even if I light cure it, I'm going to get full polymerization at the depth of that restoration and tooth interface. And one of the risks of dual cure materials is the chemistry, the chemical initiator or catalyst can cause color shifting of the cement over time. Well, you know what? In the posterior of the mouth, that's not a deal breaker. In the anterior, that can be very critical. And so we do have strictly light cured materials. We have dual cured materials. And then there are some systems on the market that are light cured and allow you to add a dual cure catalyst and convert it to being dual cured. But when we think about bonding, let's go back to our process, just like we did with cementation. So again, the first piece of this puzzle is going to be try-in. And when we think about trying-in restorations that are highly dependent upon the color of the underlying tooth for the final restoration, and an anterior veneer for me is a classic example of this, we definitely need to try this restoration in, and you cannot try it in dry. So if you try a restoration in dry, you really have no idea what the final restoration looks like because you have minimized and or eliminated the impact of the color of the dentin in the final restoration. You can try these restorations in with water. I strongly recommend some sort of a try-in paste, a translucent try-in paste, or they do come in colors if you want to try to do a little value shifting. What the different colors of cement do is they alter the value. So they increase or decrease the value. They don't do anything to the chroma or the hue of the final restoration, but they can alter the value. So we're going to try these in, not just to make sure they fit, that the margins are sealed, but so that we know aesthetically what this restoration is going to look like. And then because we're bonding, we have to prepare both the tooth and we have to prepare the restoration. So when it comes to tooth preparation for bonding, you need to be thinking about what your process looks like for that. So the first step is going to be etching. And we, all know there are total etch systems on the market and there are self-etch systems on the market. So this is a classic example for me. These are the two veneers you saw in the prior photograph, and I'm going to bond these in. And these are very conservative, minimal preparation veneers. And it's all in enamel, or 90-some% in enamel. So for me, this was the appropriate place to use a total etch, or a 35% phosphoric acid system, because I know I'm going to get maximum etching and maximum bond strengths with a total etch system. There are places in the posterior where you might be bonding primarily to dentin, and you might want to be using a self-etching system. And then today in our world, we also have something called a selective or hybrid etching technique, where you can use phosphoric acid on the enamel interface and then use a self-etching system on all of the dentin. But it's somehow you're going to have to try to think about removing the smear layer, creating demineralization so that you can get a hybrid layer. Again, many of you will want to use some form of a desensitizer and or an antimicrobial, a chlorhexidine preparation, a glutaraldehyde and hema type of a preparation, so that you're killing bacteria, you're preventing the production of what we call MMPs, or matrix metal proteinases, and you're preventing postoperative desensitivity. And then there's going to be some process of priming and then bonding. And, this is not a program about dentin adhesives, so I don't want to go into all of that, but we know there's lots of choices on the market. Everything in one bottle, 2 bottles, 3 steps. There's lots of things to think about with that. The restoration also now needs to be prepared or to get ready for this process of bonding. So the first step for that is called porcelain conditioning. And porcelain conditioning typically occurs on most ceramic materials using some percentage of hydrofluoric acid. So Emax, the recommendation is 5% hydrofluoric for 20 seconds. Most feldspathic or lucite reinforced ceramic, the recommendation is going to be between 5 and 8 or 9% hydrofluoric for somewhere between 60 and 120 seconds. And once the glass has been conditioned, you're then going to rinse this and dry this. Zirconia is classically conditioned by using air abrasion, again, small particle size, 50 micron aluminum oxide or cojet powder. You don't want to use hydrofluoric acid on zirconia. And some of the other glasses, you aren't supposed to air abrade. It's against the manufacturer recommendation. I let my laboratory do all the porcelain conditioning because they know the material the restoration is made out of. I trust them to know the manufacturer's recommendations for that. And then all I have to do is clean it. So if you're milling in your office, you're going to have to do your porcelain conditioning. But if it's been conditioned in the laboratory, you do not now need to do more etching or more conditioning. As a matter of fact, you don't want to, because you can actually damage the restoration by over etching it. So you do want to have a conversation with your lab about who's doing the conditioning. And we're going to clean. So if you had the ceramic or the material conditioned before you tried it in, so now it's contaminated with saliva, hand piece oil potentially, red blood cells, we need to clean it. Lots of ways to do this. Again, I talked earlier about using just phosphoric acid, blue etching gel, to clean the inside of the restoration. And that works with everything except for zirconia. You don't want to use etching gel in a zirconia restoration. But there are materials on the market now, like IvoClean, that are designed purely for cleaning. So whether it's phosphoric acid or IvoClean, you're going to coat the inside of the restoration, leave it for about 30 seconds, and then you're going to rinse it and dry it. And now we're going to condition, or we're going to couple the ceramic. So there are lots of materials on the market for doing that. Most of us are familiar with silane, and silane works and is approved for all of our true ceramics, our lucite reinforced and our feldspars. And then we have blended materials, so things like viscose primer and monobond plus actually have both silane and other materials in them that fall in the into the methacrylate family. They're monomers, basically, that also work on things like zirconia and other types of materials. So depending on the variety of materials that you submit, you may want to go with one of these more universal conditioning agents versus truly having silane. Couple of things to know about silane. Once you apply silane, it needs to be thoroughly dried, completely dried with some kind of a clean air source, and then it actually needs to go about 60 seconds before you're ready to actually get full bond strengths out of that. So I typically prepare the restoration first. So I'll do my porcelain etching, and then my cleaning, and then my conditioning, and then I set the restorations aside. Then I go back and I actually work on the teeth. I do my isolation and my etching and whatever I'm going to need to do next. So then I know my silane has been able to be dried and sit long enough. Then we're going to choose our resin cement. So in the family of light-cured resin cements, there are lots of purely light-cured resin cements out on the market. They all require that you follow this process of preparing the restoration, preparing the tooth. They have translucent. They have a variety of different colors. You have an unlimited working time as long as you keep it protected from light. They have great bond strengths as long as you follow this process and keep everything isolated very well, and you adequately light cure it. So probably one of the most important things to think about around a true light cured resin cement is you have to get adequate light. And for every millimeter of porcelain you cure through, every millimeter of tooth you cure through, or every millimeter of air you cure through, you need to add about 10 seconds. So this is not a place to sort of skimp on your light curing. You really want to be very generous with your light curing. A lot of people like to tack cure, so they'll seep the restoration. They'll do a quick little 2-second tack cure with a tack curing tip so that they can then clean the excess. And then I'm a strong proponent, if you're going to clean all of the excess before a full cure, of applying deox or glycerin to the margins and preventing an air-inhibited layer from then washing out your margins prematurely once the restoration is seeded. Dual cure resin cements, there are systems on the market that really fall in this true dual cured resin cement category. And again, the restoration has to be prepared and the tooth has to be prepared. These are materials that have both light curing capability and chemical catalyst to cure these materials, and they're typically systems. So they come with a dual cure dent adhesive, a prime and bond system that works. There's often a palette of colors, so there's translucent and other colors. And you're going to follow a very similar process with these when you think about dual cure. So, where do I use a light cured material? I use a light cured material on my anterior veneers, my anterior all porcelain restorations. Where do I use dual cured materials? For me, this is for posterior partial coverage restorations that have limited mechanical retention forms. So that's where I'm going to go to these systems. But in this same category, I want to go back and I want to talk about the group of materials we called self-etching, self-priming resin cements. And I talked about them under the category of cementation. Because if you're using this material under a porcelain fused to metal crown, so GSEM, Link Ace, under a porcelain fused to metal crown, that is a cementation process. But if you'd like to use, this is a material, just like a lot of our dual cured materials, that has light curing capability. It has dual curing, chemically driven polymerization or curing, and it's got components in it that actually prepare the tooth. So if you want to use this material and follow the process of bonding, so you're going to prepare the restoration. So you're going to make sure that the porcelain has been etched, that it has been cleaned and silanated. Or if you're using zirconia, you're air abrading the inside of that restoration. Now you can use this material and follow a dual cure process so that you can use this material for your all ceramic restorations. One of the things that I love about GSEM Link Ace is, for those of you who are doing zirconia, and zirconia is kind of your go-to all ceramic material in the posterior, it has a very unique proprietary formula formula, and we won't go into a lot of biomaterials here, material science, but zirconia and phosphates have a chemical interaction with one another, and the GSEM link ACE actually creates a really nice bond to zirconia because of that proprietary formula. Works as well under things like Emax or lithium disilicate. So, we talk often in our industry about what we call universal materials. And one of the things I know about universal materials is that means that the same material can be used in different clinical settings and in different techniques. But you also need to understand that using it in those different ways often requires different steps. And so using GSEM Link ACE for this is a classic example where you can use it as a cement, where it's really easy to use, it's very tolerant of the oil environment, and it'll work under any material. You can allow it to chemically cure and hold it in place for the full 4 minutes. If it's a translucent enough restoration, you can do a little tack cure, clean it to the gel phase, and then do your 20 seconds per surface cure. Or you can now move it into that realm of truly bonding and follow the steps for preparation of the restoration and preparation of the tooth so that you can now use this material. It can kind of be used universally as a cement or as a bonding. And for those of you who like the simplicity of one material, that may be something that you really want to look into, is that being able to have one material that can be used in both of those clinical situations.